Hello, everyone. Welcome, and thank you for joining us for our Halloween webinar titled Skeletons Need Strong Bones Too, Micronutrient Essentials and Nutrition Support. I'm going to share a couple of housekeeping items before we get started. This is a webinar format, which means attendee cameras and microphones will be off. We will only be able to see the presenter. And while we will not utilize the chat or the raise hand feature, you can use the Q&A function in the toolbar. It's at the top of your screen if you have questions during the presentation, and our presenter will answer them at the end. You can also submit Q&A questions throughout the presentation versus waiting until the very end. This webinar will be recorded and made available on our website at oley.org/webinars. The information provided during this and all of Oley's presentations is for educational purposes only and is not intended as medical advice. Although clinical information is peer-reviewed, you are advised to consult with your healthcare team before making any changes to your personal care plan. Before we get started, let's learn a little bit about you. John's going to pull up a little quick survey in Teams. Are you a patient, a caregiver? Are you a healthcare provider or an industry partner? Go ahead and answer that, and I'll give you guys a little bit. So we have, so far, majority healthcare providers. It's balancing out with more caregivers. We'll give a few more seconds. I see we have a combined total of about 20% patient caregivers and 70% healthcare providers, with about 5% industry partners. Now let's learn where you are joining us from. Are you guys signing in from the US, international? What state are you from? What city? Go ahead and type that in. And we'll see where we're all calling in from. Wow, okay. We have Kentucky, Boston, Pittsburgh, Colorado, Orlando, Massachusetts, Denver, Delaware, Florida, Northern Virginia. And Maggie is joining us, unless that's a city. Hi, Maggie. All right, so all over the US, we have West Coast, East Coast, and Middle. Thank you all for sharing. To get us started, please allow me to introduce your speaker. With us today is Dr. Akash Pandey. He's a pediatric gastroenterologist and physician nutrition specialist with extensive qualifications, including CNSC, Certified Nutrition Support Clinician, CSN, Certified Sports Nutrition, and diplomat of the American Board of Obesity Medicine. His practice is centered on pediatric digestive health, clinical nutrition, and comprehensive management of conditions such as obesity and those requiring nutrition support. Dr. Pandey completed the Nestle Nutrition Fellowship for Physicians, further specializing his expertise in nutritional interventions for complex pediatric cases. He has established and directs multiple specialized clinics, notably in neonatal GI nutrition and pediatric cardiac nutrition rehab, aiming to enhance patient care and outcomes. As an assistant professor and director of pediatric nutrition at Arnold Palmer Hospital for Children, Dr. Pandey is currently involved in training future specialists, contributing to significant research and authoring numerous peer-reviewed publications, continually advancing the field of pediatric gastroenterology and nutrition. Now, without further ado, I'm going to pass it over to you, Dr. Pandey.
Good afternoon, everyone. Thank you for being here. I know it's Friday evening, Halloween, so I really appreciate you attending online lecture. We'll go over some basics about the bone health, and I'm hoping that the information which I'm going to be presenting today would be helpful for you and your patients. But feel free to ask questions if you have any. We can definitely discuss towards the end of this presentation. Let me know if you're able to see the slides.
Yes, we could see the full deck.
Okay.
There you go.
Is it okay?
Perfect.
The view is okay?
Yes, perfect.
Perfect. Okay, so the topic of today's talk is skeleton needs strong bones too. We'll be discussing about the nutrition components, especially the micronutrient components of and the nutrition support. There's a disclosure. Again, this information in this presentation is for education purposes only. It is not intended as a personal medical advice and should not replace a consultation with a qualified healthcare professional. Any clinical decision should be made based on the individual patient circumstances and current medical guidelines. So I thought maybe it's going to be good not just to understand, just to know what you should be taking, or talking about just the micronutrients for the bone health would be good. I thought maybe giving just understanding about more about the bone and then building up on in terms of why the nutrition may be helpful in these patients, right? So especially optimizing on both macro and micronutrients. So what we know is there are different types of bone, different architecture. There are some short bones, long bones, and the flat bones. But the most importantly, these bones, they have different functions. The cortical bones, so if you look at the classification, the outer part of the bone, especially the long bones, are cortical bones, and the inner side of the bone is trabecular, which is more like a meshy bone. And that meshy bone is more metabolically active. It's very lightweight. It has multiple holes in it, like a honeycomb, but very active for the body processes found inside the bone end. So it does help with different, it has many different functions, the bone overall, which supports the movement protection in the very young ones that produces blood cells in the marrow, and also the calcium, phosphorus, and the growth factors, especially the calcium phosphorus, I would say, is concentrated in the bone. About 80% of the calcium and the phosphorus are there in the bones. And there are different types of, the bone formation, whether it's coming from the stem cell or basically from the cartilage, becoming the bone. But what is important in this slide is the bone development starts very early. When I say very early, we are talking about 6 to 7 weeks gestational. So within few weeks of conception, the bone is started to form. And over the period of time, it becomes stronger and stronger. And the maximum bone growth and the density of the bone is in mid-20s, when you see the volume of the bone goes up by significantly. So if you look at the bone has two different components. Third one, if you want to take water into consideration. But bone matrix, think about bone as like a reinforced concrete, right? So there's a steel rod, which is the organic component, which is flexible. But after the steel, you need a cement to strengthen the bone, which is a mineral part, right? So the organic component, which is about 30 to 40% of the bone, the main ingredient for the type 1 collagen fibers are basically, all the protein and the micronutrients, which play a significant role. And this type 1 collagen fiber is made by the osteoblast, which is a bone building cell. And then the mineral component would be where the calcium and the phosphorus is going to be there, and that also contains some sodium. The important point about the slide is that there are different parts of the bone, and most important thing is the bone is dynamic. It's a living tissue and which constantly remodels itself. And if you look at the microscopic level, the bone consists of epiphysis, which is the end bone, the diaphysis, which is the shaft, and the most important part would be the metaphysis, which contains the epiphyseal plate. The growth plate, which is responsible for the longitudinal growth in the children. So in the pediatric age group, this area is very important. And but if you look at microscopically, the bone has two different components. The cortical bone, as I've discussed previously, is a denser outer layer providing strength, and the inner side would be the trabecular bone, which is a spongy bone, basically, which is more metabolically active. And there are different types of cell, which plays a significant role in whether bone building or bone resorption. And there are stem cells, which helps the osteoblast, which is the bone formation cell, to come up. The bone goes through a different cycle from the damage. When the bone is damaged, there is a bone resorption cell which cleans and the dirty area in the bones, meaning the not the damaged bone, and then the osteoblast, which is more lays the foundation of the new bone to come in, and it's tightly regulated by different hormones and rankle and OPG, which may be too deep to go into, but overall there are different cycle of the bone, and again initially there is a bone resorption phase where the osteoclastic activity is going to go up, where the dirty bone is cleaned up and the new bone is going to form with the help of the osteoblast. This slide is very important, and the reason for is very important is as I previously mentioned, the bone started to form at a very early age, at about 6-7 weeks of gestation. And the maternal vitamin D status actually plays a significant role in the bone building. After the birth, the bone accrual is rapid in the first year, with the bone content doubling in the first year of life. And overall, as the child is growing, especially in the adolescent age group when the growth spurt happens, for example, in the girl, which is around 11, 14, and the boys are slightly late, the bone accrual rates increases by about 5 to 6 fold, which is pretty significant. And over the period of time, the bone consolidation is going to happen, and around 18 to 30 years of age, that's when the maximum peak bone density is going to be. There are multiple factors which contribute to the peak bone mass. Some are modifiable factors, meaning when I say modifiable, meaning these factors are in our control, such as the what kind of medications we are taking, what kind of exercise we are doing. Of course, the food plays a significant role, which is a building block for the bone formation. So there are about 40% of the modifiable risk factor, 60% can be genetics, and when I say genetics, it can be certain things like osteogenesis imperfecta, etc., which can lead to the bone problems. So the peak bone mass is highest amount of bone tissue a person will ever achieve, right? Typically in their late 20s, and it serves as a foundation for the lifelong bone health. So think about it as a bone bank. During childhood and adolescence, we make deposit, and after reaching the peak bone mass, we begin to gradually withdraw, from the bank. The higher PBN, which is a peak bone mass, means the larger reserve and reducing the risk of osteoporosis later on in the life. Even a 10% increase in the peak bone mass in between 18 and 30 years of age can delay the osteoporosis by between 10 and 13 years, which is pretty significant. So importantly, about 1/3 of the adult bone mass is gained in just 4 years around the pubertal growth, and making this a critical window for the interventions, especially for the pediatric age group. I think it's very important because now we have this window where we can optimize the nutrition, where we can optimize on the physical activities and things like that to help with improving the bone mass. So what are the nutritional frameworks? So we kind of touched about this content in the previous slide, but I'm just going to go over that again so that we understand more thoroughly. That bone is made up of 2 different parts. Again, there is a framework, which is a matrix part, as a steel, which is there in the bone, imagine. And then there is a concrete, which is going to be form of the mineral. So the steel, which is going to reinforce the pillar, if we take the pillar as an example, is about 30%. It's made up of type 1 collagen. Again, it's more protein and the micronutrient which makes this. And the mineral is going to be more like a concrete. So you pour the concrete in the pillar with the help of the steel is going to make it more solid. So the mineral provides comprehensive strength and rigidity to the bone. So balance is very important, because if you're going to have a lot more collagen, less of the mineral, the chance of fractures is going to be high. But if you have a lot of less collagen and a lot of mineral, that can lead to cracks, and that's going to lead to some fractures too. So this slide depicts the bone, the protein as rebar. And so bone is not just a mineral, it's about 50% protein by volume. And the osteoblast, which is basically which produces or which makes the bone, produces about a good couple of pounds of type 1 collagen each year. One of the markers which you can detect in the blood for the collagen synthesis is basically P1NP. And in the patient, the reason this may be important is in the patients who are sick in the ICU setting, the kids who have chronic inflammatory conditions, the kids with burns, fractures, their protein mass has to go up. It has to double up a lot to prevent the body from breaking down more muscle and bone from the energy, right? If the body goes through the energy deficient phase, the bone is going to start breaking down because body needs energy. So whether it's going to break down the muscle, it's going to break down the bone. So it's very important that we optimize our nutrition. This is one of the very important slide, and this is more important for the females and overall, especially the girls who are more into sports and all, because if they're not consuming enough calories, that can lead to the energy deficit states, especially the kids and the girls who are involved with the sports, because if they are burning a lot of calorie, not consuming enough calorie overall, enough protein, balanced nutrition, these children, especially because their estrogen level is going to go down. And once the estrogen level is going to go down, in the bone loss is going to happen because estrogen is also helped in solidifying the bone. So the level of estrogen plays a significant role in maintaining the bone mass, and that's why after menopause you're going to see a decline in the bone mass in the females. In contrast to that, acid load, especially when we talk about the patients who are on the metabolic, coming up with metabolic acidosis or some kidney problems or something on that line, from diarrhea or fistulas or acidic TPN formulation. Bone salts buffer the excessive hydrogen which is there, which actively driven from the bone loss. And to prevent that from happening, it's very important that we maintain the good pH, a normal pH in the blood that's going to decrease the bone resorption, also maintaining enough calorie, especially if we're talking about the red S or energy deficient space. So I think it's a combination of A, maintaining the neutral pH in the blood, B, maintaining the good nutrition, optimized, balanced nutrition would be important. So when we talk about the bone, the two main things which come in our brain is always calcium and the vitamin D. And that's why, a lot of the kids we see in the clinic, they are on the vitamin D supplementation, they're on the multivitamin. And if somebody is worried about the calcium, the bone, they worry about, they take calcium and vitamin D. And as you can see here, the RDA for the calcium changes with different age group, right? So the younger the child is, the less the RDA for the calcium is, but the peak of the calcium happens around the same age when the peak bone mass is going to go up. So around prepubertal age to around late 20s, that's when the RDA of the calcium is going to go up to about 12 to 1300 milligram per day, as compared to the older people who are anywhere between 1000 to 1100 milligram of calcium per day. The information on the right-hand side, where it says calcium carbonate and calcium citrate, the reason I brought it up is because we take calcium in a different form. Some calciums are better absorbed, some do not, right? So calcium carbonate, though it absorbs better from when you take the calcium, it is absorbed better, but there are a lot of limitations for that. So the children who are, on the acid suppression, taking calcium carbonate may not be the best thing for them because it needs acid to be absorbed. Also, you have to eat it, you take it with the food. As compared to calcium citrate, which is basically, though it is less absorbed, meaning if you take about 1000 milligram of calcium citrate, only 200 milligram of the calcium is going to be absorbed, but does not need acid. It can be taken anytime. So absorption of the calcium is saturable, so doses should be split, if possible, if the schedule allows, into twice a day dosing, then once a day dosing for the better absorption of the calcium. Vitamin D is not just a vitamin, it's a steroid prohormone essential for the calcium and phosphorus absorption. So it starts with the skin, where the UVB converts this cholesterol to cholecalciferol, which is vitamin D3. And the liver then converts it to the stored form of vitamin D, which is 25-hydroxyvitamin D, which we typically measure in the blood. I think that's a stored form of vitamin D, and whenever we check the blood, it has to be 25-hydroxyvitamin D. The storage form we measure, this is the storage form we measure clinically. Now, the active form is different. The kidney is stimulated by the high PTH, and the low phosphorus activates the 1-hydroxy 125 vitamin D. This hormone then binds to the gut, and that helps the absorption of the increases the calcium and the phosphate absorption, also modulate the bone remodeling. So again, the important point here is that the key cofactor for this is also magnesium, which is required for this step. So remember, measuring 125 vitamin D is misleading in deficiency because PTH drives its activation even when stores are low. So all this check for the stored form of vitamin D, which is 25-hydroxyvitamin D. So we talked about the calcium, we talked about the vitamin D. Now we are going to talk about the different minerals, which may be helpful for the bone mass. So phosphorus is a glue that holds the calcium together, in a simple term, with about 85% of the stored in the skeleton as a part of the hydroxyapatite. But beyond the structure, essential for the ATP and deficiency of the phosphorus which typically occurs in the refeeding syndrome, especially the patients who are not fed for a long period of time. Those kids have high risk for refeeding. So these patients may have a low phosphate level that can also impair the bone growth and formation. The chronic antacid, overall, the chronic antacid, so we talked about the refeeding, the chronic antacid use, and the hyperparathyroidism also waste phosphate. Conversely, if you look at excess phosphorus, usually from the renal failure, binds calciums, lower the serum calcium, and trigger the high PTH, leading to the renal osteodystrophy. So managing phosphorus is critical. Replete before the feeding, stop patients, and monitor for the level in GI and renal cases to prevent the complication occurring from the hypophosphatemia. Magnesium is very important because the reason it's important is because it plays a significant role in the body. It's a critical cofactor for more than 200 enzyme and about 60% of it stored in the bone. So it is important in calcium homeostasis. I cannot overstate that, because hypomagnesemia can cause refractory hypocalcemia, though it is a 3-part failure. But overall, if the impaired PTH secretion, for whatever the reason, because of the parathyroid gland needs magnesium to release the parathyroid hormone, but overall somebody does not have enough magnesium, there's going to be a lot of PTH resistance it's going to have, and also at the bone and the kidney level, and there's going to be an impaired vitamin D activation, since magnesium is required for the liver processing. So common cause of magnesium loss, GI losses, includes diarrhea, the patients who are short gut, the kids who have fistulas. Some of the medications like PPIs and diuretics can do the same, and the patients who are on TPN or refeeding state can lead to hypomagnesemia too. So clinically, what is important here is if the calcium won't correct despite repeated doses, check magnesium first, right? Replete with IV magnesium, but you can do magnesium sulfate before chasing for the calcium, right? So if the calcium won't correct and tried everything, please check the magnesium. There may be reason that if the magnesium is low, probably calcium is going to be low. Vitamin C is very important, and the reason for the important is basically it's building block for the strong collagen, which we call the matrix, right? So the collagen is triple helix, and again, it is stabilized by the different residues, and then require vitamin C as a cofactor overall. So without vitamin C, the collagen is not stable enough, and it can actually denature very quickly, and it may be related to the body temperature issues with the scurvy and all. So clinically, this is very important because if the vitamin C level is going to be low, the kids may have a high risk for fracture, poor healing, severe bone pain, some hemorrhages can happen, bleeding gums can happen. So in this situation, if somebody is low, check for the vitamin C, and if it is low, please supplement it. So takeaway point is, without vitamin C, the collagen may fail and the bone strength can collapse. So zinc it has multiple different role in the body. It is acting as a cofactor for many different enzymes, as we have seen also with the magnesium. But most importantly, it powers the alkaline phosphatase. That enzyme which the bone building cell, which is osteoblasts, use to initiate the mineralization. So zinc cannot lay down its concrete. If you can imagine that. So without the zinc, the bone will not function well, or the solidification is not going to happen. It is also essential for collagenase, which is kind of it clears the debris during the fracture remodeling, right? So collagenase does play a significant role, and without the zinc, collagenase may not function well. And for DNA, RNA polymerization also and proliferation, zinc is needed. So zinc deficiency is common in patients with high output GI fistulas, such as the kids with diarrheas. They can have low zinc level. The patients who are not taking enough or poor nutrition overall, these patients can have a low zinc level, leading to these kind of issue. So dietary sources of zinc is typically from the meats, poultry, some seafood, and supplementation often required in the form of zinc sulfate. So typically ranges between about 20 to 50 milligram of elemental zinc. And if somebody is on the TPN, it can be added to the TPN. So simply, if I have to put it together, no zinc, no bone healing. So zinc plays a significant role with the bone. Collagen, so the third part of the collagen. So we talked about the vitamin C, we talked about the zinc for the collagen synthesis. Now we are going to be talking about the copper. The copper is the final step in strengthening the collagen, which is rebar, which is matrix. While vitamin C helps for individual collagen strand, the copper, through its role as a cofactor, creates this mature link between the collagen fibers. So again, vitamin C helps with individual collagen strand, but the copper is going to bring everything together with the help of the linkage. So deficiency can happen in the kids who are on TPN without the trace element from excessive zinc supplementation, which blocks the copper absorption overall. So clinically, copper deficiency can mimic scurvy. It can present with osteoporosis. It can present with anemia and neutropenia. And typically, the sources of copper is nuts and seafoods and meats overall. Typically requires about 2 milligrams per day of copper to maintain the level. So the key takeaway point from this slide is balance zinc and copper, because without the copper, the collagen structure cannot achieve the full strength. Vitamin K, especially the K2, is essential for activating the protein that bind to the calcium. So as you can see in the slide, it acts as a cofactor for the enzyme, which is called a GGCX enzyme, which adds a group to the specific protein, and which creates a clot. The mechanism is critical not only for the coagulation factor, but also the bone health form of it. And the deficiency occurs in the fat malabsorption. The patients who have pancreatic problems, or not getting enough, or patient is losing it or not getting enough, or after the prolonged antibiotic use, or the patients who are on the long-term warfarin therapy, typically not that many pediatric patients, but more so in the adult patient population. So it reduces the active osteocalcin, increases the fracture risk overall. So the sources for the vitamin K is leafy vegetables, some fermented food, and the gut-derived quinone, which is K2. And simply put together, if without the vitamin K, the bone cannot properly mineralize overall. Vitamins, B vitamins, plays a very important role, I would say, because B12, B6, folate, they don't build bone directly, but they all prevent the toxin and the homocysteine. These vitamins are essential cofactor in the methionine homocysteine pathway. So overall, if somebody is deficient in the B12 and folate, they can have increase in the homocysteine level, and overall, there are upregulation of certain pathway which can lead to the bone fragility. So the result is brittle, poor quality bone, and clinically why it matters, especially in the patients with B12 malabsorption. If we talk about the patients with Crohn's disease, especially the disease involving last part of the small bowel, gastrectomy patients, some of the patients with MTHFR variants, being failure patients can have a high risk of vitamin deficiency, leading to the increased homocysteine and of course bone fragility. So managing B vitamin status is therefore very important in maintaining the collagen integrity and skeletal strength. Iron, manganese, and boron, they have their different role. And the iron is a cofactor for enzymes critical for the collagen formation. But while deficiency causes anemia, iron overload is also it's toxic for the bone building cell. So again, it's good to take iron, but overdoing iron can lead to the bone problems. Manganese, on the other hand, support some of the enzyme that builds the cartridge, but toxicity occurs in the patients who are on the TPN since manganese is cleared by the bile. So if leading to neurotoxicity and Parkinsonism-like symptoms overall. We started using a lot of boron nowadays, and there are some emerging role that boron boosts bone density by enhancing the calcium and magnesium use. It increases the vitamin D activation, and also it improves the estrogen efficiency. I previously mentioned that the estrogen plays a role, anabolic role in the bone health. So if the estrogen efficiency is going to be low, the bone is not going to be strong enough. So that's why taking boron and improving the estrogen efficiency may be helpful in improving the bone mass. So boron reduces the calcium loss in urine and support the collagen formation. So 1 to 3 milligram per day may be helpful. In our practice, we use some of the bone health supplement, but also some natural sources where we can get the boron, typically the prunes. There's some data on it, can be given to help increasing the bone mass. So what we have discussed till now, we talked about some of the minerals and the vitamins which may be helpful for the bone, but also I cannot emphasize on points of taking enough protein because protein helps in building the structure of the bone. It's crucial for maintaining the bone health across the lifespan. And current guidelines, depending on the age group, the protein intake may vary between 0.8 gram per kilogram per day for a healthy adult, but in the older patients, it may be it's higher. And both animal and plant-based protein are valuable, but protein only supports bone when calcium and vitamin D are sufficient. So again, you can do all the protein, but if the vitamin D and the calcium is not enough, it may still not, the bone health may still not be good. So beyond structure, protein influence bone metabolism through the IGF, which is a growth factor, and improve the calcium utilizing, making very important factor for the skeletal health. And these are the picture on the right hand side basically tells us, how the different types of protein can be consumed. Again, there was previously I would say misconception that the animal protein is the best protein, but plant-based protein may not be the best protein. But overall, there are ways to make the plant protein more complete. So both animal and plant-based protein both support the bone health when nutrition intake is balanced, meaning enough calcium, vitamin D, magnesium, etc. So I don't want this to be all about the protein or just some vitamins, but it's all about balancing the nutrition because all the macro and the micronutrients plays a significant different role in the body, right? So beyond protein, carbohydrate, and the fat also influence the bone health. The carbohydrate supplies energy and basically help with the insulin. As we know, insulin is actually helps with the bone formation. It's more like an anabolic part of it, which may enhance calcium absorption in the gut. And healthy fats, particularly omega-3s, have anti-inflammatory effect and may protect against the bone loss in chronic conditions. Fat also help absorb the key bone vitamins such as vitamin D and K. So if somebody is not taking enough fat, they may be deficient of vitamin D, and though may be taking all the supplements and other things, but if they're not consuming enough fat, the bone may not be as strong enough. So overall, we have to think about more as a balanced nutrition as compared to just one supplement over another. These are the RDAs, different age group, and depending on what you're reading. So it may change between different papers and publications. So we discussed that the calcium is a primary mineral component of the bone, and vitamin D is essential for intestinal calcium absorption. And vitamin D RDA ranges between 400 and 600, but it all depends if levels are low in certain disease conditions, such as, inflammatory bowel disease or celiac disease and things like that. Then we have to increase the vitamin D level to, more 1,000 or 2,000 international unit daily. Calcium also, the peak bone mass occurs around late 20s, so that's why the calcium RDA increases, and we have discussed this in the previous slide. So nutritional assessment and monitoring. So when the child will need a bone health assessment, and a lot of places may not have the access to the physicians or orthopedicians, or general pediatricians may be not aware of how to screen the patients. But the typical recommendations are, unlike adult, we don't routinely again screen those kids. But instead of some of the risk factor, or if there's a fracture in the history, then those patients will need some kind of assessment. So, for example, if the patient had 2 long fractures by age 10 or 3 long fractures by age 19, these patients should get a DEXA scan and full evaluation to assess for any risk factors which can lead to the fracture. We typically do it routinely for some of our patients, which especially if there is an underlying risk factor which is present, especially the chronic conditions, cerebral palsy kids, patients with immobility, malabsorption, especially the celiac disease, inflammatory bowel disease, a lot of endocrinopathies, right, where we talk about type 1 diabetes. And again, I'm going to be discussing in detail why that may happen, but Cushing disease, hyperthyroidism, some of the genetic factors, medications used, because sometimes we just keep on adding the medication, we don't take the medication away, but some of the medication definitely can cause bone resorption, and chances of fractures are going to be high on those kids. Eating disorders, especially anorexia nervosa, that can lead to low bone health. And these are the kids who may benefit from, the DEXA scan. It's not. I just want to make sure that it's not just about the names I listed here, but it's all about, any chronic inflammatory state potentially can lead to the poor bone health. So apart from the GI conditions and all, some of the arthritis, rheumatoid arthritis and things like that, can also predispose the patients to the poor bone health. So we monitor with the DEXA scan. It's a quick and easy scanning, which measures the bone health. Typically, the spine X-ray we prefer in the kids, and it's a very easy testing to be done. We do it in the clinic, but some of the centers or some of the places may not have access to the DEXA scan. But I'm pretty sure the tertiary care center may have DEXA scan, but it may take about a few minutes to get the DEXA scan, but it may help in determining how the bone is doing or how the bone health is for the patients. Some of the hallmark, if somebody is assessing the X-rays of the patients, some of the hallmarks for pediatric bone disease, rickets, if somebody has low vitamin D, these patients can have vitamin and very big, specific looking changes you can see on the X-rays. And if somebody is having the fractures and all, again, that's a sign that the patient does not have a good bone health. So I briefly touched on the topic of secondary osteoporosis or decreasing the bone density. So if this is a good flow chart to follow, because if somebody has low vitamin D level from the malabsorption, not getting enough sun, to low calcium intake, the gut absorption is low, suppose, and the serum calcium goes down, then there's going to be increase in the parathyroid hormone, which helps neutralizing or improving the calcium level in the blood. So in the bone, there's going to be increase of the osteoblastic and osteoclastic activity, meaning the bone building cell and the bone destroying cell. Both activities going to be increased, but more osteoclastic activity is going to be increased. But also in the kidney, there are different changes going to happen. But if you look at the profile, the labs, right, these patients can have low vitamin D. It's very important that the patients who have low vitamin D level on the regular basis. Not a bad idea to check for the PTH. That's a typical routine practice for in our center. So if there is low vitamin D level for a long period of time, the patient with osteopenia, osteoporosis, always check for the magnesium, parathyroid hormone. In these patients, the calcium can be low or normal. Phosphorus can be low or normal. Alkaline phosphatase typically is high because of the high bone turnover. So this is again the patient, what we call in the high, it's in a catabolic state. So there are primary causes of bone fragility, which are basically just related to the bone, whether it's osteogenesis imperfecta or hypophosphatemia, or the secondary causes which we have kind of discussed previously is type 1 diabetes, celiac, IBD, etc. So the inflammatory bowel disease, it is very common. In fact, actually, we're looking at the data from our center, and we found there's a significant number of patients, especially children who have IBD, can have decrease in the bone density from the pro-inflammatory cytokine, which stimulates this bone resorption cell and leading to thinning of the bone. So it is very important we optimize on the nutrition and also taking care of the IBD. Celiac disease, very common to see a low iron, low vitamin D, and the calcium level in the patients, especially celiac disease, which is not very well controlled. And that may be related to the low intestinal calcium absorption, which can lead to hypocalcemia. And also the body compensate by increasing the parathyroid hormone. And overall, when the PTH goes up, which is parathyroid hormone, the bone resorption cell actually is going to go up, releasing a lot of calcium in the serum. To normalize the blood calcium level. So bone fractures may happen. Type 1 diabetes works on slightly in a different way because insulin, the lack of insulin, removes this important anabolic stimulus for the osteoblast, which is a bone building cell. The secondary one would be hyper, that can more of whenever there's an increase in the glucose level, there are some unwanted products which are formed leading to the bone, in the bone collagen matrix, which can cause brittle bone. And then high glucose also damages the bone and causes more cell death. So overall, the effect of uncontrolled diabetes on the bone is profound, and it's very crucial that we the blood serum glucose level and the HbA1c levels are normal or try to be near normal if possible. Anorexia nervosa. So if the patient, we talked about the Rett syndrome in the past, the concept applies to this slide. So if somebody is not taking enough nutrition, protein, or the vitamins or energy deficit state, these patients may have the chance of fracture is going to be high because of estrogen level goes down, and estrogen is an anabolic factor. And if the estrogen level is going to go down, there's going to be a lot of stress hormone is going to go up, which can lead to the catabolic state and the poor bone health. So it's very important that we optimize on the nutrition, and it's not just about giving the protein, but giving the balanced protein, balanced nutrition, and also making sure they're getting enough energy. Okay. Hypothyroidism, the same thing. The excess thyroid hormone helps with causes bone remodeling by stimulating bone resorption cell. So overall, there's a net bone loss which can happen in the patients. And in children, this can cause rapid growth and early closure of the growth plate. So these patients are typically short stature, or they can have cranial synostosis. Cushing syndrome, where the chronic cortisol axis is there, which can lead to the severe low turnover osteoporosis by directly suppressing the osteoblast function. And also it can cause the cell death. So things to think about, again, is different conditions can lead to the poor bone health. So how we manage it, of course, we have to have a multidisciplinary approach to this, and I cannot emphasize the importance of our wonderful dietitian in this, because without them, we will not be able to actually manage this well, right? So, but it is multidisciplinary, so it's involving the docs, different specialty, the dietitians, the physical therapists, social workers, and the goal is to coordinate care and address all factors to the child health, medical, nutrition, functional, psychosocial. This is a foundation therapy for nutrition exercise, right? So it's very important that we increase the calories, and B, give the balanced nutrition, both macro and micronutrition, and the exercise is very important, both resistance training and some kind of cardiovascular exercise to help improving the bone density. So we talked about different RDAs and the protein intake and the exercise, which play a significant role. And these are some of the exercise to consider. There are some low impact, then there are high impact exercise. Of course, the high impact exercise may be helpful in improving the bone mass more than the low impact exercise. So for example, jumping is one of the good exercise for stimulating the bone. Playing basketball, playing soccer would be a really good way to improve the bone health. So, kind of going over the same kind of information, jumping exercise is a really good one for the adolescents. Muscle training, interesting that some of the meta-analysis did not find significant effect of the resistance training alone on improving the bone health of the spine or hip. But it does help with improving the muscle mass. And as we know that the more muscle mass you have, the bone mass is going to go up too. So the clinical takeaway is, so make sure you do the combination of exercise between the cardiovascular and the resistance training. So again, this may be different, depending on what patient is preferring. So there can be high impact, there can be a muscle-mediated loading, and depending on the preference, patient can do a combination of both, or one or the other. So this is the repeated information about the anorexia and the bone loss. We have to make sure we optimize on the calories, not just the protein, giving enough energies, calcium, vitamin D. Weight restoration is very important, and giving oral contraceptive may not be it has not been very useful in this patient population. So vitamin D, what are the targets? So if the vitamin D levels are low, either you can do higher dose, so 50,000 unit weekly for 8 to 12 weeks. You can do sub-Q, IM vitamin D to help in improving the vitamin D level in the blood. As we know that the low vitamin D level can lead to the low bone mass. If the overall exercise diet is failing and it's not working, then you talk about the bisphosphonate. And imagine the bisphosphonate binds to the cells which causes bone destruction. And so it kind of neutralizes that effect and leading to improved bone mass. And this is how it works. And it's kind of a little more detailed and maybe not be too relevant for this kind of presentation, but overall, bisphosphonate is commonly used for severe osteoporosis, which may help in improving the bone disease. There are other anti-resorptive agents, such as denosumab and some of the SERMs, which are new in the market. In the peds, there are some anabolic agents which can be used in the younger ones, which has been shown to decrease the fracture risk. So this is one of the important slides because the important for that is a whole body vibration therapy, which we typically recommend for our patients. It's an emerging non-pharmacological therapy which uses a vibration platform to deliver the mechanical stimuli to the muscle and the bone. So it's mimicking more like exercise, and it's particularly beneficial for children with the patients who have physical disability, the CP kids and things like that. So who cannot perform the high impact activity. And so in these patients, it may be very important because the mechanism relies on the mechanotransduction, which is a process by which the bones sense and respond to the mechanical forces. And the vibration-induced bone deformation moves this fluid through the canal which is present in the bone, which converts the physical stimulus to the biochemical signals and may help in promoting the bone health. And this is a different setting for the vibration device, which may not be very relevant for this particular presentation, but it's all about the gut-bone axis. So there are certain fermented foods can be consumed, which may help in releasing of short-chain fatty acids, which can help in better absorption of, some of the micro and macronutrients, which can help improve the bone growth. Vitamin K, vitamin D2 absorption can be better. Probiotic and prebiotic, may play a role in improving the bone mass. I typically suggest more, if possible, probiotics and prebiotics from the food itself would be the best approach. And probably this last slide is medication-induced bone loss. So some patients may be on the multiple medications, and sometimes they can be on it for many years, and that can lead to the bone loss, especially the notorious ones are the glucocorticosteroids. Patients are on the acid suppression. Previously, we discussed the patients who have, who are on the PPI or acid suppression, they can have decreased calcium absorption. Some other medications like anticonvulsants and some of the SSRIs and heparin can lead to the same thing too. So always long-term therapy, review it, consider alternate agent if possible, and prophylactic bone treatment may be initiated. So overall, the early prevention is the best intervention and screen high-risk group before fracture occurs, treat nutrition and hormone as co-therapies, and making sure education, talking to the family, I think is the most important thing. And building bone today means protecting growth and mobility and lifelong health. This concludes my talk. I'm going to stop sharing. Let's see.
Thank you so much, Dr. Pandey. I will open it up for questions. If anybody has a question, please go ahead and open up the Q&A feature. And if you don't see it right away on your screen, check the 3 dots with the more, and you'll be able to find the Q&A, and you can type in your questions there. We also have some questions that were submitted when many of you registered. So I'll go ahead and get those for you now. John and Melissa, if you could put them up, please. Okay, we have a question from Jessica. Can boron be added to TPN?
Can the boron be added to TPN? I'll have to double check on it. I'm not sure, but I'll double check and get back to you.
Okay, perfect. Yes, Jessica will get back to you. Thank you for keeping your name on there, so we'll get you that answer. Any other questions? Go ahead and add them. Here we go. Do you have a recommended list of questions along the time continuum that patients should be discussing with their providers about bone health? Like, what should people be asking at the different year mile markers? And then they said, I could say as a mother to a child on nutrition support for 16 years, we've had 0 conversations or tests about bones. So clearly this needs to be patient driven at times.
That's correct. I mean, it all depends on the different centers, and some centers may have a lot more availability of the testing and certain screening scans like DEXA scan, which can be done. But overall, the kids who are requiring the TPN, the kids who are, cerebral palsy or wheelchair immobility, overall, there is a high risk for that. So at baseline, we have to record all the anthropometrics, the puberty staging, the medications the kids are on, the children are on, including use of steroid, we kind of discussed, but also baseline labs, including the calcium, phosphorus, magnesium, what we talked about, and not just that, the vitamin levels, the PTH, which I do think that is, a lot of people don't order the parathyroid hormone, but parathyroid hormone is very important as a part of a screen for the bone health, especially if somebody has low BMD at the baseline. In addition to that, alkaline phosphatase for the reason we discussed in the lecture. But overall, I think you do the baseline. You start if somebody has low bone density, you start them on the supplements, and after 6 to 8 weeks, after the significant adjustment of formulas or the supplements, things to review again, and then typically. What I do here is if the patient has abnormal DEXA scan, suppose that if the screening is done, the DEXA scan is abnormal. Sorry. After 1 year, we repeat the DEXA again to really see how the improvement is for the most part. In the specialized clinic, in the bone health clinic, we typically do it more frequently, every 6 months, depending on how the bone health looks like. In the severe osteoporosis, every 6 months, because some supplement may be helpful in improving the bone health sooner than later. And we have to make sure that their calcium, phosphorus intake is adequate. Of course, we have to do the full physical exam, but there are some red flags, which include the new fractures, bone pain in some of the kids. They're not gaining the height, declining if the phosphorus level is low, or the alkaline phosphate is going up, definitely needs a very close conversation with the primary care doctor. If the primary care doctor is not well aware of the bone health, probably talking to the specialist might be okay. Now, in our center, we are fortunate we have the subspecialty clinic, but in that setting, the sports medicine doctor, endocrinologist may be really helpful, or they can provide a lot of resources for that. Orthopedics may also be helpful in some cases.
Thank you very much, Dr. Pandey, for the great, thorough answer. And if anybody else has questions that we don't get to today, or if you have further questions from Dr. Pandey's answers too, you can also go to info@oley.org anytime, info@oley.org. We have a few more questions. So, okay, what options do people have if they can't absorb vitamin D via their GI tract, nor get enough sun exposure? The amounts in the multivitamins aren't enough to resolve deficiency.
Yeah, and that's one of the biggest issue we see, because as the vitamin D is a fat soluble vitamin. When you consume the vitamin D, I think plays a role. So making sure it's with the food and fatty food and things like that is going to be better absorbed. First of the day, taking vitamin D supplement would be good, but taking enough, right? So there are some good data on 50,000 unit. You could, depending on the level of vitamin D, if it is less than 30, less than 20. So the vitamin D insufficiency versus deficiency, that's something we'll have to kind of classify. And based on that, either the child can get 50,000 units weekly for 8 to 12 weeks, or they can get the Strauss dosing. When we talk about the Strauss dosing, we are talking about 300 international unit, 300 international, 300,000 international unit, every 3 to 6 months, depending on what the level is going to show. And in some centers, actually, it has shown to be actually better effective in improving the vitamin D level in some cases. Now, in some parts of the world, in US it's less common as compared to others. The sub-Q or IM vitamin D can be given, especially we are thinking about the kids who have inflammatory bowel disease or celiac disease or any GI mucosal problem where we are not able to absorb the vitamin D from the lumen of the gut. So IM or sub-Q vitamin D can be given that can help in improving the vitamin D level to some degree. But also, as I mentioned, that in some kids, though you may be taking the vitamin D, if the vitamin D level is not improving, you have to understand that magnesium supplementation is important. So it's not just, sometimes it's not just about the vitamin D. Sometimes it's also about adding some cofactors like magnesium to help in improving the vitamin D levels overall. At the same time, if you really have to check some of the medications people can be on, right? So if somebody's on some of the medications, which can cause more fat malabsorption and things like that. Of course, those kids may have low vitamin D level to begin with. So that's why you have to time the medications and the vitamin D supplement accordingly. But my suggestion would be, and again, this is it's not a personalized suggestion, but overall, I recommend that, maybe first half of the day taking the vitamin D with the food would be really good if possible, but also taking enough. Not every child is the same. Everyone has their different requirement, and sometimes you have to give a little more push to bring the vitamin D to a certain level, right? And you don't want to be too high, but you want to be enough in the blood.
Absolutely. Thank you so much. And you have incredible knowledge. Our CEO actually asked a question, Beth. She asked if the list of questions for patients to bring to their providers, if you have anything written, or if you'd be able to maybe help us formulate questions. Do you already have anything available?
So what I ask, so this is more pertinent to the specific you want to talk to the provider about just the bone health, right?
Okay.
That I think that's what the question is, right?
Yes.
Okay. So in any chronic disease, it can be anything. I do think that there's an importance of breaking down the system and talking about the bone health is not going to hurt. Labs, sometimes it does not do it justice in telling us, okay, if the calcium is normal, so what? Calcium can be normal, but bone health can still be poor for the reason we discussed in the slide. So overall, I do think that, specific questions are bone pains, where exactly the bone pains are, the type of disease and how it can impact the absorption of the bone versus, not taking enough. Those are important things. Growth, if the child is not gaining weight and growing well, anthropometrics, right? So when you look at the growth chart is very important too. So whenever you see the decline in the growth chart or the patients fail to do it, right, those are the very high risk patients to begin with. So immobility, chronic inflammatory conditions, patients who have, small intestinal recurrent small intestinal bacterial overgrowth, exocrine pancreatic insufficiencies, inflammatory bowel disease, celiac disease, those kids are type 1 diabetes in the older kids and, adult population, or the patients who are on the highest, on the acid suppression, those patients are the high risk. So the question to ask would be joint pains, bone pains more so often, decline in the growth by default. These kids should be getting the screening. And we can move it to actually formulate a questionnaire, which may not be a bad idea for Oley to kind of, so that, the providers are aware, because again, this is a field where not most of, try to do, give the attention, but for some reason, it does not it does require a lot of attention, but people don't give that much attention. So not a bad idea to come with a questionnaire. So I'm willing to work with Oley to formulate some kind of question.
Thank you very much. And thank you, Dr. Pandey, for your time today, for sharing your expertise and thorough knowledge. To everyone who joined us today, thank you. Any questions that we didn't have time to address on this webinar, email info@oley.org and we will get them addressed. This recording will be made available on our website at oley.org/webinars. And if you're not already, make sure you're following Oley's social media channels on Instagram, Facebook, and LinkedIn. And you could sign up for our emails and join Oley at oley.org/join. You won't want to miss our next webinar on November 11th, a seat at the table, where we'll have a panel of people who live with home nutrition support. They're going to share their experiences and advice for navigating the holidays. Register for that at oley.org/webinars. All events are always free to attend, especially for those living with nutrition support, in-person events as well. And if you are joining as a clinician, we appreciate you and your help in spreading the word for this education to your patients. Thank you again, Dr. Akash Pandey, and to all of you for joining. Have a great Halloween. Have a great Friday.